just get in the habit of checking that, okay?
And if it is unlocked, how do you lock it?
On the side, this orange and green thing, if it's up, it's unlocked. Yeah. Also, I don't know if a lot of you guys know, instead of waiting for these buttons here, there's little pedals here that you can use. So what I did was when I walked in, I introduced myself, and as I'm washing my hands, I'm saying, hi, my name is Rochelle, blah, 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 and I'm lifting them up. So you don't have to necessarily stop at every step. Okay, well, now I'm gonna lift you up. It's like, this is awkward, right?
Yeah.
So, so you do that, right? So we've done precautions, we've done room check. What would be the next thing that I need to I need to ID my patient, because if my patient's nuts and trade beds with somebody, I don't know, you never know. Okay, what is your name?
Kimberly Picarelli.
Kimberly Picarelli. And can you tell me your date of birth?
3/24/91.
Fabulous, and she's correct. Do you have any allergies?
I do not.
Do not. Beautiful, perfect patient. What is something that we need to ask her now?
She needs to use the bathroom.
Yes. Before that, you do need to ask that. So I'm gonna ask you, yes. I'm gonna ask you, do you know where you are?
I do. Hospital.
The hospital, okay. So yeah, I'm really actually very happy you did that. So if you ask yes and no questions to a patient and they're like, yeah, I know where I am. Okay, well, where would that be, right? So don't ask yes or no questions. Close your eyes. Do you feel that?
Yes.
Okay. I could have a patient that says, close your eyes. Do you feel that? Yeah. No, you don't. So make sure you don't ask yes and no questions.
Where do
I
you
want
feel
you to tell me where I'm touching you. Things like that. Okay? So we know where we are. Do you know what year it is?
2018.
Perfect. Okay. I think so. And do you know the president? You know, it's interesting. In the hospital, everybody does that. Like, yeah, I guess I know who the president is. Okay, so my patient is AAO times 3. That is awake, alert, and oriented times 3. Perfect. Oh, you guys are good. Okay. So we're gonna do a quick physical assessment. Do you need to use the restroom? It should take about 15 minutes.
Sure.
Yeah. Okay. Your patient's not gonna say that during return demo. No, I'm good. I'm perfect. Okay.
Question about that.
Yes.
So, I was talking to one of the other students,
Uh-huh.
and let's say you have to do bedpan as one of your skills.
Okay.
Could they say yes and then do the skill then, or do you have to do the entire physical assessment first?
So when you get your paper, there's going to be things like transfer a patient, make a bed. If you have to transfer a patient, you will have that paired with an unoccupied bed making, right? Because you can't make an unoccupied bed with a patient in it, right? So you would have to move your patient to then make an unoccupied bed. Ask your professor. A lot of the times it makes sense to do it right then and there if you have that skill, right? So they're not necessarily going to know to say yes and no at that point. So ask your professor, well, I have a bedpan, so you do have to go to the bathroom now. If you're comfortable with it. If you're not, you can run through the physical assessment, like, because a lot of people just want to get it in and it's fresh and I hope to God that I know something, and you just want to get it done, do your word vomit and keep it moving. It's up to you, just verify with your professor, okay?
When you transfer the patient in a chair, that doesn't matter if it's outside the blue line?
Yeah, because this is a little awkward and bulky. That's just more so for body mechanics and that you know what side to like transfer them on and pivot them on. Makes
So
sense?
it is okay if the chair's a little...
A little bit.
They said the chair should be like close
Yeah,
to
no,
the bed
it's
as
gonna be
possible.
close to the bed, but this is big, this is awkward. So yeah, if the back left leg is out, you're fine. Yeah,
Or the arms
because
are
it's not, this space is not realistic for a hospital. Okay, any other questions? Okay, so we are awake, alert, and oriented times 3. We do not need to use the bathroom, excuse me. So first one where you're going to check your head. Do you mind if I touch you? Okay, I know that's awkward, but people, usually if you go like this, people freak out. Okay, so we are going to put on gloves. I'm not gonna do that, but we're gonna put on gloves, right? So we're looking for pediculosis, any lesions, lumps. Have you had any head trauma?
No.
Yes.
No.
This program
Yes,
had head
we
trauma. Yeah. So no. Okay. So your findings would be if we have none of those things: head is normocephalic, There's no evidence of pediculosis, lumps, lesions, and hair distribution is normal, right? We're good. You would then take off your gloves, because you are not going to continue, and throw them away. That is one thing that you will have to do, put gloves on. You do have to physically do that in your return demo. Okay, then take them off. All right, so I have a little cheat sheet here. All right, so we're gonna go to your nose. Okay. Have you had any, you always wanna ask them, especially with the face, have you had any trauma? Do you have any deviated septums? Do you have any issues breathing that you know of? No, okay. So you're gonna shine your pen light. Okay, it's free of bats in the cave, drainage, no polyps, anything like that. Can you occlude one nostril, right? And I can feel blowout, okay? Other one? Perfect.
Oh, I didn't know about the blowout and feel it.
Yeah, you could feel it just because, again,
Yeah,
like
I
if
know
I
how
say,
you
can
know
you
that.
breathe properly? And they're like, yeah. And they have no airway coming in and out of the left nostril, it's not normal. So you just wanna check everything on one side, you do to the other. So when you're stating your findings, everything is bilaterally, right? So Nair's free of polyps, drainage, bilaterally, patient can smell, all things like that. Questions?
Do
No.
we have to bring that whole like little cinnamon stick or anything like that, like the scent?
Did your professors tell you to do
Yeah.
that?
Yes.
Yes.
Okay. When I did it, we didn't, but in ortho neuro, we started to have, I bought actually, if you guys want to do this, a contact lens case, and I put peppermint oil in one side and coffee grounds on the other. Just so you're not like, well, let me pull out my cinnamon stick and my lemon, like, no. So, I mean, if that helps you guys, then by all means, you could do that. But yeah, so if they did tell you, then that would be the time that you
Okay,
would
close
do that.
my eyes.
Close my eyes.
Vanilla.
Close your eyes. Right, vanilla. Okay, and on the other side, it's mint.
But yeah,
Right.
peppermint.
You do have to do different scents, obviously, because you can't have them smell coffee and on both Nairs. That doesn't make sense. All right, so we've done that. Nairs bilaterally free of discharge, no evidence of masses, inflammation. Cranial nerve number 1, olfactory, is intact. You do have to state that. If I say cranial nerve, fill in the blank, you do have to say the name is intact, right? Okay. So your eyes. So we are going to, okay if I touch your face? Okay. So open your eyes, look straight ahead. We're gonna check if her conjunctiva is pink and moist. Her sclera is white, right? There's no discharge, there's no drainage out of her eyes, okay? So you always want to, before testing the sensory part of it, so like her eyes, you know, vision, you always want to check the physical structure first, right? So we are then going to, there's nothing really to see, but tell me what my name is,
Michelle.
okay? And what is that word?
Info.
Info, beautiful, okay. So now cranial nerve 2, optic is intact, yes? Okay. So we want to, let's see, so one thing that you do want to add in, that the eyes are not sunken in, they appear symmetrical, the sclera is white, conjunctiva pink and moist, and
Ask if the patient wears contacts or glasses.
yes, but I didn't ask. Yes,
Is Perla a part of optic?
I'm about to get into it.
Cranial nerve.
No, technically no, it's 3, 4, and 6.
Oh, it is. Oh, wrong question.
Yeah,
on the
so
test,
that's
I got.
actually what I'm gonna do, just because optic is simply your vision. Can you
Okay.
see close and far?
Mhm.
That's optic, right? 3, 4, and 6 are your EOMs. So, I mean, if you goof up and pair them in front of 2 and not in front of 3, 4, and 6, you're not gonna fail, as long as you do it, right? Okay, so Perlac, right? So we are going to, can you look straight ahead for me? Okay, so I'm going to, right, and do the other side, right? Because whatever we do to one side, we do to the other, right? Now I'm gonna go like this. What am I doing there?
Consensual.
Concentric, okay. So can you look at my pen light? Now look at that word info, and look back at my pen light. Perfect. Keep staring at my pen light, do not move your head. Okay. So if I do all of those things together, I can say pupils are equal, round, reactive to light, accommodation, convergent, and consensual. Does everybody understand why?
Mhm.
Okay. So this, when I'm asking her to stare at my pen light and stare back at that word, I'm accommodating. You should see her pupils getting bigger. This is real world. Demo, you're gonna see it, right? Everybody's gonna see everything perfect. But in real world, you are testing that because, right? Because it's easier to dig yourself out of a hole if they ask you a question if you understand what you're doing, right? So the accommodating, your pupils should dilate to accommodate for the vision that you're trying to see. Does that make sense?
Mm-hmm.
Okay. So pupils equal round react to light accommodation convergence. Okay. So now, there are different ways that you guys have been taught this. This is how I have been taught. If it's different than what your professor wants you to do, then by all means, do it how they want. But I've seen students go like this and then say, follow my pen light. Okay. Homegirl's gonna have a headache by the end of this, okay? Don't do it that close to your patient. Do it, I mean, she's a little bit tinier, but if you can, like, over her navel, pubic bone area, this is about 12 to 15 inches away from her face, and this is okay. You're still gonna see her eyes move. There's no need to be like this, right? Okay. So now we're testing EOMs, right? Don't move your head, just stare at my pen light. God, you're supposed to be a perfect patient.
Sorry.
Okay. Okay.
Sorry, it would be better.
You're fine. You're fine. All right. So EOMs are smooth and symmetrical. Cranial nerve number 3, ocular motor. Cranial nerve number 4, trochlear, and cranial nerve number 6, abducens are intact. You do have to say it like that. It's obnoxious and a tongue twister. Some will let you group them all together, like cranial nerve 3, 4, and 6 are intact. Try not to get in that habit, because if your professor doesn't like that, then you're shit out of luck. Okay? Questions up to this point?
I thought we had to do
We do,
cranial nerve,
yeah.
ocular
Say the
motor, cranial nerve.
ocular motor, trochlear.
That's why I was saying, if you guys were told to do something different, then by all means do that, because I took process in the summer, like
Last semester they didn't make us do it either.
Yeah, so it's
But
just,
this, I guess.
they change stupid things like that. Yes?
Do we have to note the size of the pupil before you dilate?
I did not. If you do, then yes.
Okay.
Yes. A lot of these are very handy.
Yeah.
And you don't have to like, oh, well, damn, she looks like a 5.5. But if you do it, pupil size is whatever, and state it. If they have you do that, then yeah, by all means.
Do it this, wow, I'm not smart. I would do it this way, like this way. So, all right, guys.
Yeah, right? Learn yourself something.
So now if there's any paralysis, would that affect your eye function?
Good question. If they have facial paralysis, possibly, depending on if they had like trauma or something to their face, by all means, maybe. But as far as like return demo goes, the paralysis is usually just on their extremities.
Okay.
Yeah. Good question. Okay, so now we're gonna look at the face. Okay, so face is even, there's no abnormal lesions, there's no edema on her face, everything looks beautiful and symmetric, right? Okay, so I'm gonna palpate your face, okay? Can you tell me if any of this hurts? No. Nothing. Do you have problems chewing?
No.
Can you clench your jaw down for me? Perfect. Release. Okay. Do you have TMJ?
No.
Beautiful. Okay. So all you're looking is for hair distribution, that their face isn't swollen, that they don't have any lesions on their face, and that there's no pain in their sinuses. That's basically what that is. Okay. Cranial nerve number 5, trigeminal, is intact. So then 7. So we are going to ask you to close your eyes, clench your eyes, raise your eyebrows, open your eyes, puff your cheeks, smile, frown. Okay, what are we looking for there?
Symmetry.
Symmetry, right? So patients who would have an issue with that would be who?
Stroke patients.
Stroke patients. So as awkward as that may seem, in real life you do need to see what, again, the degree of paralysis that they have, right? So that's the whole theory behind that. So cranial nerve number 7.
Close your eyes though, and you gotta touch the face.
Oh right, that's actually 5. I apologize.
No,
Yes.
no, I didn't know which one it was.
That's
Just-
fine. Okay, so when you close your eyes, when I'm touching, close your eyes. Tell me where I'm touching you.
This cheek, right cheek, left cheek, forehead, nose, chin.
Okay. Yeah, she is right. I forgot about 5. Yeah. So tell me where I'm touching you, not like tell me when you feel me touching you. The whole, you have to do it. And you also have to do things on each side. Notice how I did both cheeks. Chin you don't necessarily have to do because you only got one of those, right? Forehead you can do both. Just depends on what your professor wants. If you do it across the head, kind of covers your bases. Yeah. Questions up to this point? Okay. All right, so for that, the findings would be face and all structures are symmetrical. Sorry. In appearance, movement, and then cranial nerve number 7, facial is intact. Yeah? Okay. So the next one is ears. So we're going to do the same thing with our pen light. I don't see any extra cerumen. I don't see any problems here. There's no polyps, anything like that. Does this hurt?
No.
No. No pain here. So no pain on palpation. One thing that you can do when you're, don't make it a habit, because I know that everybody's nervous, don't make it a habit to be like, okay, and there was no pain on palpation. Okay. And there's actually no cerumen either. Okay. Don't talk to your professor. Talk to your patient, right? Because in the real world, you're going to be talking to your patient. You can make it easier for yourself to verbalize everything as you're going, so you can kind of keep track of, okay, I test for that, I looked at that, okay, and now we're going to do this, and now we're going to do that. Talk to your patient, because if you come into a room in the hospital, start touching somebody without telling them what you're doing, you're going to get hit. Right? Nobody likes that, right? So just talk to them, and it keeps your brain kind of on track, okay? All right, so now we're going to test for cranial nerve number 8, and I'm going to say a word on either side of your face, and I want you to
say the 2 syllables.
yes.
Watermelon.
You do have to walk all the way around.
Blueberries.
Make sure that your face is behind them. So if you're saying like this, right? Okay, you get that? So just make sure that your face is kind of hidden away from them. All right, so cranial nerve number 8 is acoustic, is intact. Okay, so now I'm going to look at your mouth. Do you mind opening your mouth for me? Beautiful teeth. Okay, hard and soft. Wow, you really do have pretty teeth. Hard and soft palate are intact. There's no bleeding, inflammation in the gums. She does have a tongue in there, so that's great. And so then we're looking for mucosa is pink and moist, right? There's no lesions. There's no cracking around her mouth, her lips, her teeth are gorged, and that's that, right? So that's the assessment part. So now I'm going to ask you, 9 and 10 have been a problem for people forever and a decade since the beginning of this program. Verify with your professor what they want you to do, okay? Because I know that some want the uvula with 10, some want trachea, like it's stupid, but so how I was taught, right, was, can you say ah? Okay, now swallow for me. Beautiful. Okay, so that would be cranial nerve number 9. Mm-hmm. I'm checking that she has the ability to swallow, because if you have a patient that cannot swallow in the hospital, you need to know about that. You need to be aware of that, right? And you are making sure that her trachea does not deviate to one side or the other. It should be center. It should be midline, right? Okay. Okay. So that's 9. Uvula is just to see if it rises and falls, right? So you actually do have to look. Say ah, okay. Uvula is midline, rises and falls, right? So that's that. That would be 10. Vagus, cranial nerve 10, vagus is intact. Again, verify with your instructor which one they want to pair with what, because I know that a lot of people have said different things. Okay? Okay, so now we're going to look at 12. So can you stick your tongue out for me? Can you stick it from left to right? And put it on the roof of your mouth. Perfect. Okay. So there's no vesiculation when your tongue is moving from left to right. No vesiculation, no shaking, and frenulum is intact. Cranial nerve 12 is intact. Yeah?
Hypoglossal.
Yes. Okay. So now I'm going to look at her shoulders. Her shoulders don't have any masses on them. Don't have any masses on them. Is there any pain when I do this?
No.
No. Can you raise? Perfect. And can you push against my hand? Perfect. And push against my hand. Okay.
Oh, your hands are nice and cold.
Shoulders appear symmetrical. There's no masses. They move bilaterally, and no pain on palpation. Can't remember if I said that.
Yeah, it's
and
very short for that.
yeah, spinal accessory 11 is intact. Questions? Great. Question?
I have a question. If we have a scenario with a patient with a paralysis,
Yes.
when we're checking for the symmetry of the face,
Yes.
do we include that in the, or that is just for movement of the patient?
You can. It depends on what paralysis. So like I was saying with her, usually it's only extremity paralysis. So only when you're working with the extremities would you have to verify that. Now, this is testing the fact that you could do this on a real human being in the hospital, so you do have to test for it. You may not necessarily have that. So like if she has left-sided paralysis, I'm gonna say, I know you have. I'm not gonna say my patient. I know you have left-sided paralysis. Not a big deal. We're gonna work with that. I'm gonna help you out when I'm asking you to do certain things. Okay.
Thank you.
Right. See, things like that. But you actually do need to do it because you need to they need to make sure that you know what you're doing at that part. It doesn't matter if they have paralysis or not. You just have to acknowledge it. Always acknowledge. I don't want to say that too much talking is not a bad thing, because I know that a lot of people can just start word vomiting, and then that is an issue as far as time goes. But you always want to talk to what you're doing, right? You never want to just start doing something and not say it, because if you were telling them what you were doing, that could have been one of your checkoffs that they know that you know what you're doing. Does that make sense?
Mm-hmm.
Okay. Question? Another one? Yeah.
When you're doing the ear test and you go to the other side,
Yeah.
are you supposed to put the rail up?
So no, as long as they have two here and you are in the room,
Not leaving the patient.
there's not an issue, right? If I were to go outside of the room, then there would be a huge issue. But because I'm here, I'm staying with the patient, you're good. Yeah? Okay. Okay, so now we're gonna move on to the shoulder, the neck, excuse me. So we're gonna look for the same thing. We're gonna inspect for lesions, any abnormalities, any edema. We are going to look for, what is a big thing that we look for in the neck? JVD, right? So I was told, I don't know what you guys are told, that you guys have to lay them down
Yeah.
and put them back up. Is that?
Yeah. That's how they want us to do.
Yes, okay. In reality, when you have a patient with JVD, you don't have to move them at all to see that they have JVD. So if you were told by your clinical instructor to do that, then do it. I think it's kind of stupid and wastes time, but who am I? So ask if you have to like put them down and then put them up. You do though have to, regardless, shine a light, because this isn't bright enough, on their neck. Okay. So what?
Sounds like that.
So we have, she's awesome, so she does not have JVD, and
Do
we're
you
gonna,
shine the light when you put them down?
yeah.
Okay.
Yeah, so if you are gonna put them down, shine the light on both sides, okay? So patient is negative for JVD. Next thing that you wanna do is you're always gonna check for pulses. You're not necessarily gonna take the pulse unless your instructor tells you otherwise, but you are gonna feel for their pulse. One thing you do not wanna do when checking the carotid pulse.
Both at the same time.
Okay. I saw somebody do that. You are not going to do this to a patient. Okay. That, I'm pretty sure that you would get failed for that. Okay, because you're not going to kill anybody today. Not today. Okay. So, carotid pulse is +2, easily palpable, and regular. You never want to say normal. Normal for one patient is not normal for the rest of society or for your next patient. You could say regular, right? Okay. And you do want to check both sides. Again, everything that you have two of, you want to check both of them. Right?
Okay, one question about the
Yeah.
JVD.
Mhm.
When you put the patient down,
Yes.
you actually can see the distension.
On a
right?
regular patient?
Yeah, when
Yes.
they are lying down.
Yes.
And then it's just, they will gradually disappear
Correct.
when they sit up,
Correct.
but then you don't see it.
Yes.
Uh-huh.
I was saying, usually
why they
with
lay 'em
somebody who
down.
has JVD, they have heart failure. It's a very sick patient, so you don't have to lay them down to put them up, because in reality, laying somebody down with heart failure is not comfortable for them, right? It feels like there's an elephant on their chest, they can't breathe to begin with. So it just doesn't make sense to me for you guys to be taught like that, because you don't want to do that to a patient. But yes, you do. That's the theory behind it. Yeah.
Thank you for that.
Yeah. So carotid pulses 2+, easily palpable. Rate is regular. So the next thing. So the next thing you want to check is what?
Bruise.
Okay, so a lot. Okay, so bruise are with the bell or the diaphragm?
Bell.
Bell. Why?
Because it's for
Low
high
pitch.
No. Is it high pitch?
Low pitch.
Good. You guys know a lot. Okay. So, Ms. Kim, can you please look to the left and hold your breath for a second? Okay. Am I going to hear anything if she has a bruise?
Yeah.
Swishing.
Swishing. And it actually sounds just like yeah. So patient is negative for a carotid bruise, right? So now we're gonna move on to thoracic, right? So again, we're gonna inspect. Chest is perfect. You are a great patient. There's
I like the
no
meds.
lumps, lesions. I don't know if they told you, ladies wear a sports bra, because you will probably have to get naked. It is what it is. You know, if you're doing it with your partner, thank you. Yeah, it is what it is. We have to touch people. We'll be best friends by the end of the day. It is what it is. So chest is great and
Never mind.
so the chest is free of lesions, lumps, any edema, any craziness, any abnormal freckles, lumps, things of that nature. When I'm here, what am I checking for? Skin turgor. What does skin turgor mean? Dehydration. So you don't have to, I guess it depends on if you like your partner that much. It doesn't have to be a solid, you don't have to hurt anybody. It's just a solid pinch, because people who are dehydrated, it will stay up a tent. You don't have to do much for that to happen. Okay? Questions? No. Okay. So we're gonna do the moles, edema, check for skin turgor. Skin turgor, skin is elastic and negative for tenting. That is the verbiage that you need to use, tenting. Great. Is any of those things you guys haven't heard yet? That's good. Okay. All right, so now we're gonna move on to, so I was taught to do heart sounds first and then lung sounds. Is that how you guys have been doing it? Yes, okay.
Is it heart and lungs?
No, I thought it was.
Heart. I thought it was lungs and
Yeah,
heart.
I think they want us to do one.
Okay,
I don't know.
we could totally do that.
I don't know.
All right, so we will do lungs first. So everything, again, bilaterally, everything you listen to one side is listened to on the other. So there are, I know, some professors that want you to check on the trachea.
Yeah.
Is that everybody?
Yeah.
Okay, LeVon never made me do that. I kind of think it's silly, but whatever. So you check on here, trachea, and is it on either side?
No.
Both sides.
Just here.
Just
There, like right here. Sorry. Just
No,
smacked
you're-
myself.
You're good. Okay, so after
Bronchi.
you've Jesus Christ, after you've done that, okay, so we're gonna go right above
Clavicle.
the clavicle, right? So here's 1, 2. Now we're gonna move down, just like that old. I don't know if you guys are too young. Oh my God. That video game Snake on your phone. Please, somebody
Nokia?
say yes.
Come on, who Nokias?
Oh, sweet Jesus. Okay.
90s babies.
That's exactly how you want to snake down their lungs, okay? So if I go on one side, I'm gonna listen to the other. Now we're gonna go down one intercostal space and then the other. One intercostal space, then the other. Depends, from here down, it depends on if your partner has
Chest or not.
chesticles. If they do not, you're in luck, or if it's a little bit, if they're a little bit flatter, Because if you have big tatas like myself, you can't go very far because there's a lot here, right? So that, and that's just in real life, right? So I can't, if I have a huge, you know, you can't go very far. So at that point, you would go down and then go back up. For men, doesn't really matter. We have all the space in the world. So ask your professor how many lung sounds they want. That is another one that people have.
11 on the front.
11, that's across the board.
Yeah.
I think so, yeah.
Okay.
And 10 on the back.
We haven't like gotten
10 on the back,
individualized
11 on the front.
Because I know that some, like at one point when I was doing, there was 14 on the back and 12 on the front. And, like it was a mess.
I think Professor Rhoda told us 12 in front and then
If
10
you
in
have
back.
12 on the front and you count 11, it's more about placement and the fact that you know that I need to listen from one side to another and top and bottom, right? Because if a patient has pneumonia on the top, you might not hear anything on the bottom and vice versa, right? So you can't stop here, you have to listen to the lower lobes as well. Does that make sense?
Mhm.
Okay. So we're going to do here, vesicular, vesicular. As soon as you get here, what are these?
Bronchoscopy.
Bronchovesicular. What are they louder on for vesicular?
Inspiration.
Okay. I learned Beck's Vin, if that helps anybody. Beck's B, broncho, expiration, louder on expiration. Beck's Vin. Vin, vesicular, louder on inspiration. If that helps somebody. So then usually they're about 2 to 3, depending on your professor, as far as getting down here. For ladies and men, you can just visualize, you never want to go below the bra line, right? Because if I'm listening down here, I'm listening to either on bowel sounds in the front or her kidneys in the back, right? So if you want to give yourself a landmark to stop at, you always want to stop at the bra line, okay? And then go up from there. Are you guys doing 3 on one side and 2 on the other?
They said it doesn't
No.
matter.
No.
Okay. That was another problem. Okay, so as long as you snake and listen to the front, they're not gonna count that you only did 11 on the front and you're supposed to have 12. Like, don't stress about that part. As long as you don't go below the bra line, you are listening to things bilaterally and you're moving from one intercostal space on one side to the other, you'll be fine. So, on the back, it's the same exact thing. If you were to, thank you. If you were going to visualize a sports bra, follow that line, right? So you're still gonna do the same thing as far as like above the clavicle on your back, right? Vesicular, vesicular, and then go down from there. You wanna stay, so her scapula end right here. You don't wanna go out here, because you're not gonna hear anything over bone. It doesn't matter how hard they breathe, right? So you always wanna stay here, but you don't wanna be in the center, because that's, again, bone, right? So if you stay as the shape of a sports bra, you're golden, right? Does that make sense to everybody? Again, never going below where her bra line sits. Okay, questions?
Are we gonna listen over the sports bra, or do we have to do the whole under thing?
No, over the sports bra is fine. You don't have to, because that, first of all, you're not gonna hear anything anyway, because your stethoscope's gonna be moving against the sports bra. So as long as you know placement, that's more of what they're concerned about than actually hearing different things. You do have to say, when I'm stating what breath sounds these are, you do have to say vesicular louder on inspiration, bronchovesicular, then, you know what I mean? Like, you have to do that. Yes? Okay. Alright, so, what's next? Yes, so here, we're gonna say no adventitious sounds noted. I had to say in upper areas and lower bases. If you guys don't have to say that, then don't. But you do have to note that there's no adventitious sounds noted, right? And respirations are regular, 12 to 20. Yeah? Okay. So what's the next thing? Chest expansion. While your patient is up and you're listening to the back, you want to do chest expansion, right? So we want to, right, like at her bra line, we want to have her breathe in, and if my thumbs pull apart and they come back together, that's normal chest expansion. Does everybody understand that? Yes, okay. Thank you, yes. And then we're going to check for, what does AP diameter check for?
Barrel chest for like COPD.
Barrel chest. Damn. All right, so barrel chesting. So what you're gonna do is place your hand on the front, hand on the back, same places on each side, and pull out. And this should be less than half the transverse, right? So this patient is a negative for barrel chesting. Yes? Okay, good. And what else? Okay, so now we can move to heart. So, again, you have to state everything that you're listening to. Do you guys have to do Erb's point?
Yes.
I learned American people eat too much, a pig eats too much, whatever helps you, whatever. Okay, so you're gonna start with, what is this?
Aortic.
Okay, where is it?
On the
Second
right
intercostal
side,
space.
intercostal
Right.
space.
Right. Second intercostal space, left sternal border.
Colonic.
Fourth third
Third.
intercostal.
Erb's point.
And then
Fourth.
tricuspid.
Okay.
And then
So you do have to state right aortic is right sternal border, second intercostal space. Left sternal border, second intercostal space. You have to say all that. It's obnoxious, but you have to say it.
And S1 or S2 is louder.
S2 is louder on,
aortic and pulmonic.
right?
Erb's
then
point's
equal.
Equal.
And then S1 is louder.
Okay. What is the landmark for mitral?
Booby. Nipple.
Below the nipple.
Boobies, right? Boobies.
In the mid-clavicular.
Mid-clavicular, right. Another thing, you have to say that, mid-clavicular, fifth intercostal space. So, some professors did make students listen to that. Again, verify.
1 full minute.
Yeah. And that's another thing, you do have to state, and I would listen to it here for 1 full minute. Yeah? All right, so now we're going to move on to, you are so helpful. Okay, so we have, for all those heart sounds, we would state S2 or S1 is louder, there's no murmurs noted, normal sinus rhythms, and we have an apical pulse of fill in the blank. Okay, so in the abdomen, okay, another thing, you want to ask about bowel movements, okay? Have you had a bowel movement today? Perfect. Is that normal for you?
It is.
Okay. You want to ask, that's another thing you want to ask, is that normal for you? If they say, I haven't had a bowel movement in 2 days, okay, well, is that normal for you? Because there are some people who don't, you know what I mean? So if it's normal for them, then there's no cause for concern. If it's not, then that is an issue, right? Because people being in the hospital for long periods of time, you know, they're stagnant, they're not moving, things are messed up to begin with, so that's something that we need to know, okay? All right, so in this area, I would not ask about menstruation or anything like that. That's usually after, but just make sure that you do say that. Okay, so again, we are looking for abdominal distension, if there's any lesions, if she has any scarring, anything that's abnormal, anything that looks funny, that's what we're looking for, right? So, I'm gonna go and start palpating her.
You look, listen, and touch.
Right. So, do we know why?
Because you could change the pulse.
Yes, you guys are smart. Okay, so we are going to listen to all 4 quadrants in a U shape. How long am I listening for?
1 minute each. If you hear sounds. If you don't have sounds, 5 minutes.
Okay, so you were listening to, in all 4 quadrants for 1 minute each. If they have 5 to 35 bowel sounds, it is normal. If they have less than 5 hypoactive, more than 35, it's hyperactive, right? If you do not hear a bowel sound, how long do you have to listen for?
5 minutes.
Golden, right? So I'm gonna listen. Right? I'm gonna listen, okay. And then we're going to listen for what other bruit is here?
Abdominal aorta.
Abdominal aorta, where is it?
It's between the xiphoid process and umbilicus, a little to the left.
Right. So if I'm gonna touch her xiphoid process and her umbilicus, my middle finger, if I meet and go over, that's usually where it is, right? Hold your breath. No? Great. I can hear your bowel sounds from
I'm
here.
hungry.
Okay, so no abdominal bruit, sorry, thank you, noted. And what else do we have here? Okay, so now we are going to palpate. How do we palpate? awkward
Like a
turtle.
worm.
Okay. So like this, right? And you're gonna push. Do you feel any pain? No. Then perfect. Okay. Sure. You're welcome. One last thing. So you don't obviously have to do that because that's just really invasive. But when was your last menstrual cycle? Do you go to the gyno often? Do you have like anything having to do with your genitals? You will ask at that point. Guys, do you do normal prostate checks? Do you go to the doctor often? Do you have any drainage? Anything that I need to know about? Anything like that? All that is, you just have to verbalize. We're not touching anybody. We're not touching anybody there, okay? Questions up to that point? No, golden. Okay. So again, you just do, as far as the abdomen goes, clear of lumps, edema, abrasion, scars, all that good stuff. Everything's normal. So the verbiage for the abdomen, soft, non-tender on palpation. Skin is dry, and we're good there. Yeah. So now we're gonna move on to extremities. Okay. So she has, again, no edema, no lesions. It's the same thing. When you're inspecting, you're really inspecting, unless you're inspecting in a cavity, you're really inspecting for the same thing, right? So the only thing, like her ears and her nose, I'm just looking for polyps, any deviated septums, things like that. But as far as the skin goes, you're looking for lesions, moles, anything out of the ordinary. If she has scars, inquire about it, document about it. A lot of people, when they come into, like I work in the OR, so if somebody comes in and they have a huge scratch on their arm, we have to document that, because if they come out and say, where did this come from? I didn't have that. Well, you did before you came in, so it kind of saves your ass. Yeah? Okay, so we have perfect skin on both sides, blah, 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 blah. When I'm checking for temperature, yes, so I'm going to check on both sides, and you're going to do it at the same time, because if we have one cold extremity compared to the other one, that's a little bit of an issue we need to inquire about. But if both extremities are cold just because she's a colder individual, not so much of an issue. Does that make sense? Okay. So then we are going to, at the same time, because we're not going to kill anybody doing this, is feel for our pulses, right? So 2+, they're equal, easily palpable. You do have to do the brachial and the radial. Right? Okay, so now we are going to do, I want you to close your eyes and tell me where I'm touching you.
Forearm.
What side?
Or right. Left forearm. Left bicep. Right bicep.
Perfect. You can open your eyes now. You win. I'm going to check her cap refill on both fingers. You don't necessarily have to do this at the same time, but you do have to do it on both sides. Right? Okay. So we are going to do range of motion, right? So do what I'm doing. So, okay, so paralysis. Again, if you have to test your patient to see what they are capable of doing. However, you do have to verify it, or acknowledge it, just like I did earlier. I know that you have paralysis in your left side, and that's okay. I will help you if need be, but just do what I do, okay? Ask your professor, because Laban did not want us to do passive range of motion, right? So if she couldn't move, that arm sat there, right? So the other arm was moving. Ask your professor what they want you to do, okay? So if she doesn't have paralysis, okay, do what I do, okay, and then we're gonna do flexion, extension, pronation, supination, and then can you push up? Okay, push down. Grab my fingers as tight as you can. Beautiful. And sorry, I don't know if that was you or me. Push out and push in. Good. Right? Questions? Okay. Verbiage for that would be, again, anytime that you're doing pulses, the strength 2+, equal, easily palpable. Cap refill is what? Brisk. And what's less than 2 seconds? Brisk in less than 2 seconds. So CMS is regular. No abnormalities, range of motion active, and normal findings. That's what you would do for the CMS, right? So now we're gonna do the exact same thing. You do have to touch your partner's feet. I apologize about it.
They're clean, they're stained. My socks are clean.
So same thing, we're looking for edema, we're looking for any abnormalities, skin is fine. Again, doing the same thing. So I'm not gonna take your socks off. I actually don't like feet, but you do have to do that. I'm sorry. You do have to do that. You do have to take the socks off. You have to do cap refill. You have to do all that good stuff. Okay? All right, so same thing. Push down against my feet, pull up against my feet, push in, right, out, and bring your legs to your chest. Perfect. Okay? Same thing. CMS is intact. Am I done?
No.
What do I have left?
Home and signs.
My back and my butt.
Are they having you guys do home and signs?
I think it depends on your professor.
Okay. Verify that, because they've actually in real life have started to tell people to not do that, because patients who are high tendency to have those can like throw clots and stuff like that. So just ask, because they were starting to veer away from that when I was doing it. So just ask if they want you to do that. But everybody knows what home and signs is. Okay. So you would, if you are going to do it, feel your patient's calves. Usually people who have issues here, you can feel that they're hot, right? But you want them to flex their feet and right, and see. That's all right. We'll get there. It's fine. And see if they have any pain in their calves. That's the only thing with home and signs. Okay. So now we are going to have my patient lay all the way down, and we are going to check what?
Back.
What are we looking for? Okay, so okay. So now.
No, my weakness, sorry.
So I will, if I have my patient laying on their side and I move from this side, I would put this up because they're on their side. Does that make sense as to why? Okay. So now I'm coming on this side. I am looking at all the points that would normally have the tendency for pressure ulcers. So I'm looking at her ears, her neck, her shoulders, I can see her elbows, but anything on her back, her sacrum especially, because that's a biggie. Everybody knows that. And then just to make sure that there's no redness. If there is, you need to document. We're looking to make sure that her spine is intact. There's no issues as far as curvature goes. And then for hemorrhoids. Do you have it?
Nothing sticking out. We're good.
No, we're good. Yeah, that's basically about it. And then you would.
Tell me, ma'am.
You would. Yes, no, okay,
Thank you.
Absolutely, no problem.
My weakness.
This is so fabulous.
And we all passed return demo.
Yay! Round of applause for
Only
everybody.
that would be real.
So I am done, and